Vishwa, can we begin now?
Yes, Dr. Kunal, we can begin.
So you just go make it live and give me a heads up that we are live, and I'll start.
All right. So now webinar is live.
Okay.
Yes. We can begin. Webinar is live now.
Thank you. Good evening, everyone. It's my pleasure to welcome the esteemed group of audience to this much-awaited iTrust webinar. I'm Dr. Kunal Srivastava, and I'm here to welcome you to this iTrust webinars, which actually celebrates 20 years of innovation, 20 years of trust. Actually, after US, Europe, India was the first one to bring in insulins, start producing insulins. And that is something that we are celebrating. We at the Wockhardt, we were the first one. And in these iTrust webinar, we actually discuss vast topics related to diabetes, insulin, biosimilar insulin, and all the various topics that we see that actually matters in the clinical practice, that is actually going to change the outcomes. And that is going to help all our esteemed guests to, again, help the patients to get better fast. Today's agenda looks like this. The first 5 minutes of welcome and introduction by I'm Dr. Kunal Srivastava. I represent the medical affairs of Wockhardt. Today's topic is really interesting. I know biosimilar insulins, in a sense, we can say it actually started from India. And what is the Indian perspective? And to talk about it, it's my pleasure to welcome Dr. Nishant SK sir. He's a senior consultant physician and diabetologist. Sir is also medical director at Sivagiri Srinarayana Medical Mission Hospital at Varkala, Trivandrum. Consultant in internal medicine, diabetes as SK's Center for Internal Medicine and Diabetes in Trivandrum, India. He got his degrees from the institutes like Rajiv Gandhi University of Health Sciences, the undergraduate, and the MD degree and Bachelor of Medicine and Surgery from Calicut Medical College. He is professionally affiliated to Association of Physicians of India, RSSGI, Indian Medical Association, and with the vast more than 15 years of experience, I'm definitely sure that we all will be enlightened by his expertise in the subject. So with this, I welcome Dr. Nishant sir for his oration on biosimilar insulins and Indian perspective. Sir, the stage is all yours.
Thank you, Kunal, for the wonderful introduction. I believe the slides are visible.
No, not yet, sir. If you can reshare it once again.
Yes. I think, is it visible now?
Yes, the slides are visible. If we can just make it in a presentation mode. Yes, sir. Perfectly fine, sir. Over to you.
So once again, thank you, Dr. Kunal, for the wonderful introduction. And good evening, my friends. And let me thank Wockhardt for giving me an opportunity to talk on this subject. That is biosimilar insulins and an Indian perspective. As we are aware that in 2023, we are at the midst of a pandemic, not only the COVID, but of the lifestyle illnesses. Especially, we are having a lot of burden with regard to type 2 diabetes. So Indian perspective is that we are adding on millions of people with lifestyle problem, especially diabetes. So that is really having a toll on our economy, having a toll on our output. So having a healthy population is what we need at present as well as in future. So with that idea and with that introduction, how can a biosimilar insulin fit into the Indian set of population, and how can we manage diabetes, and how can we control the complications of diabetes? So what is actually biosimilarity? So the agenda of the topic, I'll be discussing primarily about the biosimilarity and what is biosimilar, and how and what is the definition and what are the different regulations. Also, I will be discussing about the evidence of various biosimilar insulin and how can we treat using biosimilar insulin confidently, as well as understanding various interchangeability options and what are the different regulations what we have. Also about the clinical pearls of wisdom for biosimilar insulins. So we know that India has made significant strides in the development and applications of various biosimilar insulins. In the crucial part of diabetes management is that they can be more affordable alternative to various reference or what we say as innovator insulins. So there are different regulatory framework which looks into how a biosimilar can be used clinically as well as in the population as such. But we, like me, a lot of people have an experience for the last few decades in using a biosimilar. And we are pretty confident about the clinical efficacy, the side effect profile, and also the benefit, both economically as well as the overall acceptability of the medicines or what a biosimilar molecule is very well known to all of us. But there's been in the last few years and last few decades, probably the availability of the biosimilar insulin has increased, and it has reached a sizable number of the patients with diabetes, but still that is pretty less. It has to reach the benefit of the biosimilar molecule should reach a vast percentage of the population. India is also manufacturing a large amount of biosimilar molecules as a local manufacturer. And as I mentioned about the economic benefit, there is an affordability in terms of the cost, also about the quality concerns. So basically, when we talk about a biosimilar, how that is different from that of a innovator brand or innovator molecule. So biosimilars are biological drugs that are highly similar to an already approved reference product. So that is, the biological drugs are complex molecules which are derived from living organisms such as proteins, antibodies, or nucleic acid. So it has to undergo various approval process. The safety and efficacy has to be highlighted, and there is something called as the interchangeability, which I'll be discussing after a few slides, and the impact on the market. So this slide shows that the similarity of function and the biological activity, that is the biologically active part of the molecule, have same composition and conformation as determined by an analytical inspection. But you look into this, there's a non-functional part of the molecule which may have some differences in the composition as well as in the composition and conformation. And when we look into the art of biosimilar, we know that there is a significant amount of knowledge, expertise, and state-of-the-art capabilities that are essential for consistently producing high quality, safe, and efficacious biosimilar that have been the same impact on the patient as the original medications. So I'll be discussing about a few definitions for more clarity on this topic. That is basically the biosimilar. That is, as I mentioned before, it's a biological product that is highly similar to that has no clinically meaningful difference from an approved innovator product. Innovator product is that the first version of a biological product that receives regulatory approval. That is otherwise called as an originator or reference product. Then about micro heterogeneity, there is minor differences in biologic products resulting from natural biological variability and from manufacturing changes. Something about a nocebo effect. This is that the phenomenon whereby the negative perceptions or the negative thought can lead to adverse treatment outcome. This is very important these days. As you are all aware of the fact that the thinking process which undergoes through every patient, or an anticipated negativity about a product probably can lead to more negative outcome. Also very bad patient outcome. So this is exactly in opposite to that about a placebo effect. The placebo effect is something in which the trust in the doctor, the belief in the medicine that can give more positive outcome and a wonderful cure or outcome, and the belief the medicines can add to the overall betterment of the condition. So this is the term is about the nocebo effect, which is exactly opposite that of the placebo effect. And the non-medical switch is the practice of switching treatment in patients who are clinically stable for a non-clinical reasons such as course. This is very common in our scenario, where the sizable number of the patients of our population need to pay from their pocket for the medications. And auto substitution is the practice of replacing one product for another at the pharmacy level without notifying or seeking the approval of the prescriber. So that is self-explanatory, and it needs no comment on this, because most of us are going through this situation. So definition of biosimilars, there are different definitions for that, but here in India, the similar in what is biosimilars according to the definition is that it's similar in terms of safety, efficacy, and quality of a reference biology, which has been granted marketing authorization in India by DCGI, or is approved in various countries or in European Union, Japan, US, or Canada. The WHO or World Health Organization's definition is a biotherapeutic product that is similar in terms of quality, safety, and efficacy to an already licensed reference biotherapeutic product. So here, the discussion is about the development pathway of biosimilars versus innovators. As we all know, in a molecule to be developed, it takes many years to reach a clinical stage. So when we compare a biosimilar with that of an innovator brand, the innovator brand or the original molecule has to definitely prove the clinical efficacy first. So the clinical efficacy is the first and the paramount important for that of an innovator brand. Then we study if it is efficacious, then we need to underline, or we need to study more about the pharmacokinetics, pharmacodynamics, then the clinical, biological, and physiochemical aspects. So there is traditional innovators approach is to establish an efficacy and safety first. But when it comes to biosimilar, which I personally feel that this is something which is compared to an innovator, biosimilars have something easy about, because here we are the confirmation of the biosimilarity can be done by showing the phase 1, phase 2, but a physiochemical and biological characterization phase of the biosimilar development program are more comprehensive to generate a highly similar product. That is, in a biosimilar approach, it is more about establishing a clinical equivalence with the originator drug. So sensitivity to detect differences with the reference products, it can become, when you see the picture, you can see that it's something an upside down line. So to really show the efficacy or the approach in the biosimilarity is to establish clinical equivalence through the pharmacokinetics, pharmacodynamics, and also the clinical efficacy with the reference drug. Again, just to mention about the biosimilarity. For biosimilarity, totality of the evidence, a risk-based approach is considered, whereas the developer can estimate the degree of residual uncertainty after critical steps in order to plan for appropriate studies to address the uncertainties. Phase 3, efficacy and safety studies are regarded as confirmatory. So the phase 3 is the only phase which shows the efficacy and safety studies, and that can be considered as confirmatory when in the case of a biosimilar. So evaluating evidence of biosimilar insulins. And here we'll be discussing about a few studies where we'll compare the efficiency, the efficacy, the side effect profile, and it's a large study which we discuss here. There's an insulin biosimilar compared to the reference products. There's a 14 RCTs involving 6,188 patients, and that access the long or short-acting insulin biosimilar to the originator. Here, after the change in HbA1c is looked into after 26 weeks, after 52 weeks, as well as the change in the fasting level. So different parameters were assessed, and the outcome is that there is no significant difference in glycemic control between the biosimilar and the reference product or the innovator brand. Also, we compared between what are the achieving the target HbA1c at 26 weeks in patients with both type 2 diabetes as well as in type 1 diabetes. And the outcome or the result is that no significant difference in glycemic control in type 1 diabetic, type 2 diabetic, or people reaching target HbA1c between the biosimilar and reference product. Here, no discussion of the diabetes is over without discussing hyperglycemia. And here also, whether it's an innovator product or of a biosimilar, there is no significant difference in hyperglycemia events between the biosimilar and reference products. Also, there is also the antigenicity is, or anti-insulin antibody positivity is an important point which we look into when we compare a biosimilar with that of a reference product. And there's no significant difference in immunogenicity between the biosimilar and reference product. Here, the next slide is about the evaluation of the safety and efficacy of Glatis versus Landis. So it's in combination with the basal bolus regimen. Here, in combination with insulin Lispro among adults with type 1 diabetes. It's a phase 4 study. The inclusion criteria is type 1 diabetes for more than 1 year. The age is between 18 to 55 years. HbA1c more than 7, on insulin for more than 1 year. They agree to have regular injections of insulin when willing to comply with protocol procedures. The primary endpoint is change in HbA1c from baseline till the end of the treatment. And the confirmatory endpoint is change in FPG, also dose, and the hypoglycemia from the baseline till the end of the treatment period. We have also looked into the various exclusion criteria about anemia, alcohol or drug abuse, receiving more than 1.4 units per kg per total daily dose of insulin, and history of allergy to insulin preparation, receiving insulin of animal origin in the past 3 years, and receiving immunomodulatory medications or hypoglycemic agents 4 weeks prior to screening. And each week, the dose of insulin got titrated to maintain a fasting blood sugar level of 80 to 120 milligram. So it's a 12-week trial and an open label randomized control trial where we compared the safety and efficacy of Wockhart's Glargine was compared with that of Sanofi's recombinant insulin analog. So here, the results and interpretations are the efficacy and safety profile of Glargine is similar to that of the innovator Glargine and in line with the safety characteristics expected from an insulin product. And the difference between two treatment arms is not significant. The upper limit of that is 95% of confidence interval is 0.32, which is less than US FDA specified non-inferiority margin. Thus, Glargine is non-inferior to innovator Glargine in glycemic control. With regard to the fasting blood sugar glucose, the difference between two treatment arms is not significant. Hence, there is no significant difference between the two treatment regimen. The change in Glargine dose, the difference between two treatment arms is not significant. The immunogenic response, that is the anti-insulin antibody, there is no significant immunogenic response to Glargine compared to innovator Glargine. There were no reports of any hypersensitivity events or SAE reported. Adverse event analysis, that's at least one is reported in 21 subjects, that is 12.3. All adverse events were mild to moderate intensity, no clinically significant vital signs, physical findings, or other observations. So next is about the understanding interchangeability and the regulations to healthcare providers and their perspective. And the interchangeability is something where different regulatory authorities are giving different definitions to. That in effect, one or the innovator product or the reference product can be substituted without the prescribers or the doctors or the healthcare providers prescription. So that is something all about the interchangeability, and many of the biosimilars do have an agreement on biosimilars have an agreement on interchangeability, and so designs of different switch studies for interchangeability, as it can be well, it's aware of the fact that an innovator molecule may be substituted with a biosimilar, and then again how the parameters were looked into, and again changed to the biosimilar. So it's all about a switch study. So the switch study is it's self-explanatory. We know that it's going to we are looking into the parameters and how the patient and its parameters reflect when the patients are being switched from innovative brand to a biosimilar. So here the study design and the subject disposition is that is the comparative evaluation of pharmacokinetics and pharmacodynamics of insulin, glargine, and Landers in healthy subjects, a double-blind randomized clamp study. So here the study is double-blind, it's randomized, single center, 2 sequence, 4 period, 2 treatment crossover glucose clamp study to compare the pharmacokinetics and pharmacodynamics and following 2 single subcutaneous doses of Wockhardt's insulin glargine injection with an innovator glargine. So this is the study design. And when it comes to the pharmacokinetics, the pharmacodynamic as well as the pharmacokinetic aspects, bioequivalence is basically comparing the pharmacokinetic properties of 2 molecules. Here it is the innovator as well as the biosimilar. Pharmacokinetics is that we look closely into what happens to the drug as such, how the drug is absorbed, how it is metabolized, how it is distributed, and how it is excreted. So that is being looked into and it's compared. So bioequivalence is the comparison of these 2. So in that way, the bioequivalence analysis shows that there is a similarity is demonstrated if the 90% of confidence interval of the primary endpoint parameters are within the predefined acceptance limit of 80 to 125. So primary PK endpoints confirmed bioequivalence as the confidence interval 90% of the geometric LS mean, which was like the area under the curve and the Cmax was entirely contained with the bioequivalence interval. So whether it is a biosimilar or an innovative brand molecule, the comparison shows the similar pharmacokinetic parameters. So when it comes to the pharmacodynamic, the pharmacodynamics is essentially we look into the aspects what the drug is doing to the body and what are the changes that the drug is doing to the physiology or doing to the body, and to compare this property of the pharmacodynamic properties of the insulin glargine formulation. It was again compared with that of the Landers using euglycemic clamp technique, and also here also the similarity is demonstrated if the 95% confidence intervals of the primary endpoint parameters are within the predefined acceptance limit of 80 to 125. Again, what the study shows is that the bioequivalence analysis shows is the primary PD endpoints confirm bioequivalence as the confidence interval of 95% of the geometric LS means because of the area or the ratio for the area under the curve and GR marks was entirely contained with the bioequivalence interval. So the pharmacodynamic and pharmacokinetic profile is, and in a way, the bioequivalence is more or less similar with for a biosimilar molecule when compared with that of an innovative one. So what are the clinical pearls of wisdom for biosimilar insulin? And in the start of my talk, I described about the burden, what the diabetic or the lifestyle problems can bring to our country as such, and the burden and how to the economic burden, the output, and also since we are our population is primarily dependent on our own income to pay for the medications and the treatment cost. So the burden on us is pretty high comparing with many other countries where the health insurances and the governmental policies takes care of the health. Probably with a very high population like us, it may not be possible for the government or the government policies to cover entirely for the lifestyle illnesses. So health economic roadmap of diabetes in India and we are adding millions of people yearly from a pre-diabetic state to that of a diabetic state. And we are unfortunately, with all the knowledge, with all the technology, we are not able to get back or to get hold of the pandemic as such. So the cost of the diabetes is pretty high. The lifetime cost for all drugs used in diabetes is estimated to be more than 90 lakhs per individual. So also we can say that there are a lot of factors which are responsible to it, like the sudden urbanization, socio-economic transitions, and probably that is a factor, but the change in the lifestyle, the change in the diet, this change in the stress level, change in the sleep pattern. So all those things can definitely add to the burden and the cost, which is something which is we all have to think about. So the cost of the drug has to be it has to come down at a significant level, so that the treatment becomes more and more affordable for our set of population. And the biosimilar are really cost effective, and that especially for a long-term treatment, when we can reduce the burden, financial burden, especially of the medicines, by switching over to a biosimilar at the right point of time, and if we can continue with that, probably we are adding a relief as well as life to the patients. So in India, the real situation is that still biosimilars have not revolutionized patient access to treatments. Similar efficacy and safety for similar clinical outcome. Also, there is a lower cost and increased access to medications. So what is the quick guide in initiating or switching to a biosimilar insulin? Is that to consider a biosimilar as the first choice, and you can think about the clinical, socioeconomic, and patient preferences. And switching to a biosimilar insulin is switching in individuals with stable glycemic control must be validated with an expected benefit. Again, the clinical, socio-economic, and patient preferences. And in optimal glycemic control patients, it is prudent to start biosimilar at a 10% lower dose than the originator insulin, and then titrate back to the original dose as necessary. For those with poor glycemic control, a switch to biosimilar is always reasonable, and in addition to tracking the underlying reasons for the poor control, that is also very important. So poor glycemic control, the tackling the underlying reasons for the poor control assumes the first priority. Then, of course, switching, if the economic aspect is an important factor, then switch to a biosimilar. But economics is not only the factor determining. We discussed that biosimilar is not inferior to an innovator brand. If glucose level is high or HbA1c is above target, the biosimilar should be initiated at the same dose at the originator insulin and upgraded subsequently as necessary. And with persistently low glucose level or below target HbA1c, it is appropriate to reduce the starting dose by a biosimilar by 20%. So different safety aspects need to be considered. And prescribing insulins by brand name is important to avoid inadvertent substitution in the dispensing process. Consider potential differences between insulin in terms of delivery device and administration. Also, the cold chain maintenance, that is storage condition and shelf life. Encourage individuals who switch to monitor glucose more closely to identify any variability in glucose profile compared to the reference insulin. So in summary, biosimilar insulins are typically cheaper than the originator insulins. They are based on, and their use could significantly save cost. In insulin-naive individuals, use of a biosimilar insulin may be considered as a first-line option. according to the various local policies. Individuals already taking insulin should be switched to biosimilar equivalent after discussing with a clinician with expertise in the field. Glucose levels should be carefully monitored after switching, either a weekly monitoring or even, if possible, a daily monitoring can be advised. Thank you. Jai Hind.
Thank you so much, sir, for such a wonderful oration. And it was definitely an in-depth knowledge what you had shared with us about biosimilar insulins. So we are open to the questions. If you have any questions, you can put it in the chat box. Meanwhile, sir, before we receive any questions, what have been your experience with biosimilar insulins?
Thank you, Kunal, for the wonderful question. Because for the last not only few years, I think I should say, for the last 10 years or more than that, probably you're using it clinically. See, apart from the PKPD and all those reference lab values and all those studies, when you look into it, it's more or less efficient, or I should say, depending upon the patient profile, it's more showing more efficacy either in lowering the blood glucose or also in tackling the glycemic variability. So also a feel-good factor that's also there, because when the cost is less, it has automatically a good feel-good effect on the patients as such. So overall, there is nothing, no complaint to be made from the side of a biosimilar molecule in the last 1 decade of my experience.
Thank you for that, showing that confidence in biosimilar insulin, sir. I think you mentioned looking at the patient profile. So
yeah.
If you can like to share that, what is the patient profile that you're looking at and considering biosimilar, or it is just the same and maybe it's just one or two factors?
Why? Because in my experience, what I learned in using a basal insulin, whether it is a biosimilar or a non-biosimilar, is like when we initiate somebody on a basal insulin, and depending upon the patient profile, because some patients will be insulin resistant, some patients probably are not doing the adequate lifestyle modifications. Some patients are not sticking on to the diet. Some patients are not sticking to the exercise. So what the good outcome as a treating doctor who cares for the patient in 2023 is to tackle the glycemic variability. So when we really motivate a patient to look into the multiple factors, all the factors, then along with that, if you add on a biosimilar injection, you really see a really wonderful response, a really wonderful improvement in the quality of life. Overall glycemic variability, then the control is achieved. So that is what I try to mention about the patient profile. So not only the parameters like that of an HbA1c, the body weight, the fasting blood sugars. Okay, it's easy for us to target the fasting blood sugars and adjust the blood glucose. It's agreed, but look into all the other factors. A lot of factors has to have a role in the glycemic control, and looking into the multiple factors and adding on to a biosimilar insulin will work wonder.
Thank you, sir. I think those are the actual clinical pearls that we are listening now. So there's one more concern, and I think I'm not really sure what is the clinical implication, because immunogenicity maybe has been blown out of the proportion, maybe from the era, and it is the history that we carry forward from the animal-based insulins and now. And still it is being discussed when we are using recombinant insulins, be it the originator or be it the biosimilars. Now, my question is, have you seen any impact of immunogenicity per se in the clinical practice or the outcome of the patient.
How on using a biosimilar, how is the immunogenicity? So because when we as a clinician, like me and all the doctors here, we primarily target to improve the quality of the life of the patient. We primarily target to bring the glycemic control. So in the last few years of the practice, and the clinical relevance of immunogenicity is yet to be looked into for clinicians. But I had seen a patient, but it's who had some antibodies, as we mentioned, which probably could be because of an insulin, but that patient was not on a biosimilar molecule. So labeling biosimilar as the cause for immunogenicity, I totally disagree with it. Any insulin, for that matter, can even based on various newer technology, even so some patients, and very rarely we can elicit immunogenicity. So labeling biosimilars for that, in my clinical experience and in my experience, I totally disagree with that.
Thank you for that. Again, sir, you have shown lots of confidence in biosimilar, and it has also given me confidence to ask this question. Meanwhile, if you have any questions, you can put it into the chat box. So recently, we have been hearing a lot about interchangeability. Mostly a legal concept in US where a pharmacist can interchange to any brand which has interchangeability status without the knowledge of doctor, as you mentioned. So how much you would be comfortable in interchangeability status of, let's say, any insulin?
Dr. Kunal had really nailed that question, because anybody who is practicing in India, we are facing that issue. My experience may not be different from somebody who is in Mumbai or Delhi or anywhere for that matter, because it may be a little bit sad to know, or the regulatory process in our system may not be that enough, because sometimes our prescriptions are changed without our knowledge, or even the bystander or the patients or the bystanders may request for a different insulin. So all those things have got factors, that is the economic factors, the availability factors. But when we as such, like when we have a biosimilar molecule which is pretty equivalent in almost all the aspects, whether it's pharmacodynamic, pharmacokinetics, clinical efficacy, the degree of hypoglycemia, so all sort factors, then the interchangeability should be a welcome move. But the problem is in here, we practicing doctors are not confident enough whether we or the patient, for that matter, will get the prescribed biosimilar as such. Even that may not be even interchanged. So that is something which I see. Probably all of us experience it. So that has to be regulated. But interchangeability, in no doubt, for biosimilars should be accepted.
Thank you, sir. In fact, as you showed one of the slides where you spoke about how to prove interchangeability, the busiest slide, I think, that you have to have 4 switches, 5 switches. And in fact, we do have that trial with us, but still we have not, at least in India, we have not that trial in US, but we also don't want to go ahead for interchangeability per se, because having a studies and having a status are 2 different things, because we understand the emotions and the concerns when a doctor prescribes a brand. He has a thought process, kind of confidence, and looks at the credibility as to how he has his experience behind that particular brand or insulins or whatever it may be. Yes, sir. And it was really nice knowing all these intricate topics about biosimilars. And I think one last question, sir, because as you mentioned about the regulatory requirements, where phase 3 studies are only confirmatory. That means it's not a requirement per se by regulatory bodies. Still, if any biosimilar wants to conduct it, they can do it. But still, I think in biosimilar, sometimes the problem that is faced that you don't have a big, huge study to talk about your data. So what's your thought on that, sir?
Very nice very nice question, in fact, because maybe I may be a little bit critical about the system what is following in India probably. See, some molecules are available in the market for the last many years, and why at this particular point of time, when we are because of the cost effectiveness, because of the effectiveness of the medicine, we want to penetrate more deep into the population. So already an established medicine which is available currently in the market, and why we want to emphasize more on the clinical trial for more data so that is, I think, maybe a different topic altogether. But since the molecule is available for a long time, and we discussed about the pyramid. One is the inverted pyramid, and so probably that will fetch the more idea and more confidence to the practicing physicians.
Yes, sir, definitely, sir. Because for biosimilars, I think it was the charm is the affordability of bringing everyone to the same level. And if we also start conducting big, huge trials, then maybe the cost and affordability is the something that will be lost. Definitely, sir. Thank you, sir. It was really nice interacting with you, and definitely a wonderful oration. And now we have come to the end of the meeting, and for the vote of thanks and summarization, I'd like to invite Mr. Vishwagaurav, who heads the marketing for us. So over to you, Mr. Vishwa.
Thank you, Dr. Kunal. And before I move towards vote of thanks, I would like to share a great news with you all that this year we are celebrating 20 years of India's first biosimilar insulin, which is Wosulin. So in 2003, we launched Wosulin and proudly put India on the map of the global insulin manufacturers. So before Wosulin, insulins were produced only in US and Europe, and India became the third country who started producing his own insulin. So Wosulin becomes India's first biosimilar insulin, and Wosulin was developed and manufactured at our Aurangabad facility, which was inaugurated by the then President of India, Dr. APJ Abdul Kalam. So I would like to extend my heartfelt thanks to all the doctors and the medical fraternity for supporting Wosulin so that Wosulin can complete 20 years. So thank you very much for Wosulin. And now, I would like to begin by extending my heartfelt gratitude to Dr. Nishad SK sir for truly enlightening and informative presentation. Sir, your expertise and knowledge have truly enlightened us on a subject of utmost importance. To our esteemed delegates, thank you for taking the time to join us from different parts of the country. And obviously, your participation have added immense value to this gathering. And I extend my sincere thanks to Dr. Kunal for skillfully steering the discussion, and Dr. Sanket Nevale for providing medical inputs. A special mention goes to our IBB President, Mr. Amrit Medekar sir, for his vision and leadership. And my gratitude extends towards LCS Sri Vishnu sir for his support and guidance for organizing this webinar. And lastly, I would also like to express my gratitude to all my field colleagues and HO colleagues who have worked tirelessly and worked hard to ensure the smooth execution of this webinar. Concluding here, thank you all once again, and we look forward for your continued support towards iTrust webinar. Signing off, thank you everyone. Thank you.
Thank you very much.
Thank you, sir. Thank you, everyone. Have a great day ahead.
Thank you.